gene therapy has actually turned out to be probably safer than most people expected, at least so far. The key things, however, people need to appreciate is that so far in hemophilia, there have only been less than 100 patients who've had gene therapy, and the very maximum they've been followed is 6 or 7 years, and the vast majority have been less than 3 years. In terms of safety of those, there is only really one issue that has come up, and that is abnormalities of liver function tests. And that tends to occur in anything between a third and a half of the patients. Of those, that what appears to happen is that they develop abnormalities in their liver function test, but the patients remain well. And the reason it's significant, however, is because in many, if not most of those patients, it appears that the abnormality in liver function test also is due to the immune response. So when that happens, patients appear to lose the effects of the gene therapy. So it becomes quite important that you try and stop it with steroids if you can. Animal gene therapy trials in hemophilia have gone for much longer than they have in humans. Nothing has come up in those clinical trials that would be a safety concern. The animals in non-human primates and dogs are much longer than humans, but again, no major issues have come up. As far as other diseases that have had gene therapy, again, no major issues, but what has to be appreciated, however, is that in hemophilia is the leader in gene therapy. So the other diseases are behind hemophilia. So if there is going to be a problem with gene therapy, you're probably going to see it in hemophilia first rather than in the other genetic diseases. The promise of a cure is there for everybody. However, the key in all this is safety. And I stress it again, less than 100 patients followed on average for less than 3 years. If you're a patient, is that good enough for you to go for a new treatment? Some patients are likely to go for it, and they will go for it irrespective of the follow-up. Others, however, will want to wait for a much longer time to demonstrate safety before they try the therapy. In terms of the risks of gene therapy, the liver function tests are seen in about between a third and half of the patients. They tend to reflect abnormalities in the laboratory test, but the patients remain well. It can reflect, in the majority of cases, an immune response against the vector, and you can lose the effects of the gene therapy, which is potentially an issue. Another potential side effect of gene therapy that people talk about is cancer. However, the types of gene therapy that are used currently in hemophilia with AAV vectors, they do not integrate into the genome, at least they do not integrate significantly. So they would not be expected to have cancer as a major side effect. They possibly or probably integrate to a very small degree. And the important issue is if that small degree of integration, if it goes next to an oncogene, will it increase the risk of cancer? We don't know that. There have been no cases of cancer in gene therapy in hemophilia, but we probably will not know this answer for another 10 or 20 years. Another side effect that people talk about is the risk of thrombosis. And if you increase the levels, will there be a risk of thrombosis? That's not really been a big issue because all except one trial, the levels achieved have been relatively low. The problem, however, is if you get very high levels of expression, that potentially could be an issue. Again, we have not seen any cases of thrombosis in gene therapy trials. Toxicities, when you're giving the vector, that usually is well tolerated, and other than the liver function test abnormalities, there have been no major issues with gene therapy to date. The benefits for gene therapy is really the minimum a patient should expect is to prevent bleeds, prevent spontaneous bleeds. The initial trials achieved factor 9 baseline levels of around 5 to 10%. And with that, you would expect not to get any spontaneous bleeds. However, the more recent clinical trials have been getting to much higher levels. So a patient going to a clinical trial now would be expected probably to get the benefit of not getting any bleeds even after injury, and possibly even at times of surgery, not to require any treatment. The question is regarding monitoring of the gene therapy. And in practice, it's actually easier than the question probably assumes, because you don't actually have to monitor the vector. You can monitor the result. And the way you monitor the result is by measuring the factor 8 or 9 that is produced by the gene therapy. And that's what we do every day in clinical practice. So by measuring the levels of the factor in the patient's blood, we know whether the gene therapy is continuing to work or not. The question relates to whether you can develop inhibitors to the vector. And the answer is yes, but we don't really call them inhibitors in this setting. You essentially develop an antibody. So once your body has never seen the vector, and you give it to the patient intravenously, the body will recognize it as foreign and will make an antibody to it. However, it takes a few days for the antibody to be made, and by that time, the vector will have gone inside the liver cells and will start producing the effects of the gene therapy. So although you're developing the antibodies in the peripheral blood, they're against the vector, which is already within the cells, so it doesn't really affect the expression of the vector. The time that, however, becomes more important is if you have to have a second dose of the gene therapy. At the moment, that is not planned. However, if at any time you ended up having to have another dose of the vector, it will not be possible to give that vector because you made an antibody to it, you made an immune response. There are lots of research groups that are trying to see how that can be overcome, and there are some very clever ideas about how it's going to be tried, but at the moment is not really a significant issue. Gene therapy really, in the vast majority of patients in hemophilia, has been there for about 2 or 3 years, at least in the papers that have been published. We have no long-term experience. There is one trial that was in a small number of patients that are now probably 6 or 7 years since it was completed. But really, the long-term side effects, we do not know. You have to wait and see what will happen with time. If a patient goes into a gene therapy and expecting a cure, they have to remember 2 key things. One of them is that the gene therapy may not last forever. And the thing about it is that although the cells in the liver are infected, they turn over, and you may lose some of the gene therapy over time. We do not have any long-term data on that, and we do not know if the loss is going to be very minor or major. Time will tell, really, whether that will be an issue. The second problem, or not really a problem, the second issue that the patient will need to remember is that the cells that are having the gene therapy are the liver cells, and the person is not having a genetic cure of their hemophilia. So if a person who's had gene therapy then goes on to have children, then their daughters will still be carriers of hemophilia because they will have the abnormal X chromosome from the father. The current regulations from the FDA and the EMA for the current gene therapy trials is 5 years. That's a requirement that the companies will do that. And no doubt that will happen to a very detailed respect. In my opinion, however, patients should be monitored for life because we need to know what happens in 10, 20, and 30 years. It's unlikely that that will happen through companies because the companies will not invest to following these patients long term because it doesn't happen with pharma companies to follow up patients for so long. So in my view, what will probably happen is that there will be international registries, or preferably a single international registry, that all patients who receive gene therapy will be entered and followed up. That's not so novel, because in patients who receive heart transplants, who receive kidney transplants, who receive liver transplants, who receive bone marrow transplants, the patients are followed up long term and they're entered in these registries. So you know, if patients have had a bone marrow transplant, you know what's the outcome in 20 years' time. And we need that for gene therapy in hemophilia as well. How you can have a bleed after gene therapy, you need to appreciate that there is variability in the levels of factor that you get after gene therapy, both within trials, but more importantly, between trials. 2 of the gene therapy trials, the patients achieved levels of between 5 and 10%. And levels of 5 to 10% is what you're achieving now in hemophilia B with the current prophylactic therapies. And so those patients, although probably unlikely to get spontaneous bleeds, they may get bleeds after injury. The more recent trials, however, have been achieving levels of 30, 50, or even 100%. And once you're getting levels of over 50% in the gene therapy trials, it's highly unlikely you're going to get a bleed, even after injury, and many patients will be able to have surgery without any treatment first. That's an interesting question, whether you can develop an inhibitor after you've had gene therapy. Inhibitors tend to occur in young children, usually in the first 50 exposure days. Patients who are having gene therapy, at least at this stage, is patients who are adults and who have had usually hundreds of exposures. And the risk of inhibitors in that group is very low. So I think the risk of inhibitors after gene therapy, although it will be monitored, I think in my view is going to be very low indeed, if it's a real risk at all. An interesting question, however, is whether you can use gene therapy in patients with inhibitors in the first place. Because what could happen if you do gene therapy in a patient with an inhibitor, the gene therapy can work in the background producing low levels continuously of factor VIII, and that can act as immune tolerance induction, or ITI, who will then tolerize the patients, get rid of the inhibitor, and then the gene therapy then continues and provides the gene therapy as in other patients who have not had any inhibitors in the first place. The question really relates to the risk of thrombosis and the level of expression. The normal range of factors in humans is between 50 and 150%. The first trials achieved factor IX levels of about 5 to 10%. More recently, the 9 trials, and especially the 8 trial, have had levels in the normal range. If you have sustained levels above the normal range, it increases the risk of thrombosis, but the risk is not great, but it will be higher than average if your level is persistently above the normal range. And really that's the reason why companies are not targeting the higher end of the normal range. Their targets are the lower end of the normal range, because even if you slightly overshoot, you'll still be fine. So the risk of thrombosis is not that great, and so far in the gene therapy and hemophilia trials, there have been no cases of thrombosis. The issue is that as people grow older, the risk of heart disease increases in every patient, including patients with hemophilia. The risk of patients in hemophilia has traditionally been lower because they are protected from heart disease because their factor VIII or factor IX levels are lower. When you are then entering old age with normal factor VIII levels, then one would expect that the risk of heart disease would be same as the general population. I would not anticipate that it will be higher than the general population.